Great. Thank you very much for the invite, Adam, and Peanuts teaching series. So today's my talk's going to be on the pediatric C-spine. So I have no conflict of interest. And so what we're going to do is, the C-spine is such a big topic, but we're going to basically focus on some aspects of it. So we're going to briefly review the C-spine development / embryology. We're going to review the more focus on the developmental pathologies, because in terms of the spine, so many things can affect it. Obviously, the big thing that we know of is trauma, but I want to do something different for the sort of more pediatric focus. And then through that, we'll understand the multi-imaging features in the developmental anomalies that affect the pediatric spine. And hopefully we will learn together. So, and this is what we're going to get through today. All this sort of gamut of developmental anomalies, predominantly the odontoid issues, Klippel-Feil, basilar invagination, and then we'll round off the talk with achondroplasia. We're not going to talk about Chiari's because I think that's a pretty well covered topic. So before we go there, let me just text my fellow, because I obviously have a stat CT. And I can't. Okay, never mind. Okay, so right. So how does the C-spine come into form? So basically, it starts very early in utero. So from the 5th to 6th gestational weeks, we start seeing that the vertebral bodies undergo chondrification. Then fast forward in time, we have about 4th gestational month, the ossification centers start to appear in all the vertebral bodies. And then, quite surprisingly, the ossification continues throughout adolescence into young adulthood. And so basically, vertebral bodies develop from cartilage, then into bone. So we'll start off with C1. So C1, otherwise known as the atlas. So that the C1 and C2 are different, as you already know, from the other vertebral bodies. For C1, there is 3 primary ossification centers. So we have both the illustration plus a little CT image here. So we have the anterior arch, and then we have the left and right neural arches. So the neural arches appear by the 7th fetal week. Now, in terms of the anterior arch, it's really sort of a postnatal thing where it starts to ossify. And so about 20% of the population, the anterior arch is ossified at birth, and the majority, so roughly sort of 80%, you'll have the anterior arch is ossified by 1 year. So why does it matter? I think it'll matter in terms of when you start looking at X-rays, because these little babies and kids can get X-rays for trauma in particular. Now, the neural arches fuse posteriorly by 3. So I want you to remember 1, 3, and then the neural arches will fuse with the body by 7 years of age. So we have 1, 3, and 7. So hopefully that'll be a nice, easy to remember. Now, here's a CT image, and here we have a CT from a 27-day-old. You can see that here, this is the star is where the anterior arch is meant to be. So it's unossified. It's present, it's cartilaginous, it's just not ossified, so therefore it's very hard to see. But you see both the left and right posterior neural arches, and you can quite clearly see that they're not fused posteriorly. So then here, as you move forward in time, there's a baby CT from a 22-month-old, and here's the anterior arch, and this is a normal variant. You can have a bifid anterior arch, otherwise known as a split atlas. And here you can start seeing the posterior aspect of the neural arch there. Right. Okay. Now, and this is just one little tip I want to show the trainees. So here, this is from a trauma CT. Okay, so as I said, the anterior arch doesn't necessarily have to be fused, and this is a 17-year-old. You can quite clearly see that there is no sort of ossified anterior arch here, but also posteriorly, the posterior neural arches are not fused. So don't confuse that with a fracture. Now, other clues that you want to think about in terms of, is this a normal variant versus an actual fracture, especially with, the common history of trauma / MVP / pedestrian, whatever. You basically want to look out for straight edges, localized soft tissue swelling, and, this C1 is a ring. So you want to think of it as like, it's got to break like a ring. So if there is one fracture, there has to be another fracture too. And then here's just to illustrate the point about the anterior arch of C1, and especially on plain films. So we have a 5-month-old here, it's clearly ossified. Here's the anterior, and then that way you can nicely get the AI, the allanto axial interval measurement. And this is a radiograph from a 7-month-old, and you can quite clearly see that the anterior arch is not missing, it's just not ossified, right? So, right, now we can move on to C2. So the C2, otherwise known as the axis, is very unique. It has a more complex development compared to all the other vertebral bodies. And I've basically tried to distill it down to some sort of more simplified general rules as to the ossification times. So again, we have 4 ossification centers. We have the odontoid process, we have the body, and then we have the ×2 neural arches, right? So here's a coronal view, schematic drawing, and here's a lateral view of that. Now, the fusion of the neural arches, again, posteriorly occurs at 2 to 3 years of age. And then also the neural arches will fuse with the body by 2 to 3 years. There are literature out there saying 3 to 6 years, but I like to have this as a general sort of simplified rule to make it more easier to remember. And here's just illustrating what the C2 looks like in various stages of life. So from 27 days old, you can see it's very sort of, it's a young appearance, and then it starts forming more at the age of 22 months. And then you can see it more clearly. It's sort of more the usual form by 4 years of age, and it's clearly fused here. And then you can start still seeing the synchondrosis between the body and the lateral neural arches. And here it is on the coronal view. So here is a 27-day-old and the same patients at 3 years and 3 months. So this is actually quite important to remember, and just to have it in your data bank, because you can get trauma affecting the C2. In particular, sort of you can have diastasis or enlargement of this synchondrosis. And I've seen a case of that. Now, there is a, so the C2 also has the secondary ossification center at the apex of the odontoid. So here it is. So that appears at 3 to 6. So remember, back to the numbers, you have the sort of, the neural arches with the body, and posteriorly 2 to 3. Then we have the odontoid with the tip to 3 to 6, and then it should fuse by 12 years of age. Now, failure of fusion will form that os terminale, and the os terminale typically lies above the transverse ligament. So this os terminale is, quite clearly see here, is thought to be a normal anatomical variant because it doesn't have any particular surgical implication. And we'll talk about it a bit more in terms of, you know, how do we differentiate the os terminale from the os odontoideum, and so forth. Okay, so next, staying on with the C2, so the C2 body fuses with the odontoid by 3 to 6 years, and here's that subdental synchondrosis. We see it all the time. Here it is on the coronal plane, it's sort of residual, and as I said, it's visible till sort of you know, into early teenage years, but it can still be visible throughout a third of the population throughout their life. So again, not to be confused with fracture. And I know it's very easy and simple to talk about this, especially in a lecture setting, but these are rules that you know, especially when you're on call, you have to like think. Oh, you have to think on the spot. So, okay. So next, the rest of the C spine obviously consists of C3 to C7, and here they all basically exhibit the same developmental pattern. The ossification centers is present by the 5th gestational age. And again, to simplify things, you have the body, and then you have the left and right neural arches. The neural arches fuse posteriorly by 2 to 3, and then anteriorly with the body by 3 to 6 years of age. Now that I think kindly leads on to the os odontoideum. So what is the os odontoideum, and why is it important for us to know about? So there are a couple of theories of what the os is, or the os odontoideum. Some people think it's a congenital developmental anomaly. Some people think that it may be a result of a post-traumatic injury, and no one really knows what it is. There is increased incidence of the osteoidoidium in some of these entities, morchios, multiple epiphyseal dysplasia, and what's even more common than these two is Down syndrome, or more commonly known nowadays as T21. So that is very prevalent. So and the os odontoideum has important surgical implication. The odontoid process can be separated from the body, and the os odontoideum can also be asymptomatic. And here are some examples of it. So in terms of the classifications, there are two types of the os odontoideum. It can be orthoptic, i.e. the ossicle in its normal expected position at the tip of the dens, or it can be classed as dystopic, where it is displaced or located elsewhere. So it can either be, the ossicle can be located near the occiput, it can be more located towards the clivus, and there can actually be fusion of that os with other bony structures, i.e. the anterior arch of C1. Now, both types, both the orthoptic and dystoptic type, can lead to allantoaxial instability, because it is thought that there is no restraint from that transverse allantal ligament to restrain and help when there is allantoaxial motion at the C-spine level. So that's why it is particularly surgically important. It has to be fixed. So how do we recognize the os odontoideum? So the shape and size can vary, but it has a very smooth cortical border. So and also really the os is associated with more of a hypoplastic dens, right? So the actual like dens is hypoplastic. Here, I also want you guys to appreciate that here the clivus is blunted here. It's like there's like someone took a pair of scissors and chopped the tip off. So it's blunted. You can have pseudoarthroses formed with the os odontoideum with either the clivus or with the anterior arch. Okay. And so that can lead to sort of subluxation. Now, this is just an example of the os on os odontoideum by MRI. So this was a case, it's an on-call case several years ago. And so this was actually a brain study versus actually a dedicated cervical spine study on MR. So the patient came, and he was a teenager, came from elsewhere, and was being seen by other places routinely, and they came for sort of pre-surgical planning for neurostimulators, and there was no actual history of any sort of cervical spine anomaly. And so what you can see here on this like brain MRI, first of all, you can see sort of the sort of fluid signal between the hypoplastic dens here, and then you have another osseous structure. You can see the marrow signal, and here's the anterior arch. So there's increased like fusion, and here you can see that there is this sort of additional structure, osseous structure with a hypoplastic den. So that should make you think that this is an os odontoideum. In terms of differentiating that with the os terminale, you have a more of a normal size dens with an os terminale. So that will help you differentiate between the two. And then now you can also clearly see that craniocervical junction is narrowed. And here, even on the sort of both the T1 and the sort of more T2 base, there is narrowing of that caliber of the cord at the craniocervical junction with abnormal intermedullary signal. So they've been having issues that have been unrecognized, and so there's already sort of established myelomatia of the cord at this level. And then so the subsequent CT definitely confirms that this was an os odontoideum, and they were actually fixed. They went on to a suboccipital fusion within the week that they presented in a semi-emergent fashion. Okay, so, and as I say, sort of in terms of differential for the os odontoideum, it's that persistent os terminale, and just want to show you, highlight, this is the little os terminale initially, but then this is what it could look like as the child ages. But you can quite clearly see that the dens is not hypoplastic like we see. It's more normal in height, and it will still be, the os terminale will also still be sort of smooth and well corticated. And hopefully that leads us quite into sort of the first entity that we're going to discuss is the Klippel-Feil Syndrome. So it is a complex condition presenting with abnormal fusion of the cervical spine, and it is failure in terms of the normal segmentation of the C-spine in Klippel-Feil Syndrome in early fetal life, between the sort of, it's been said, sort of 3rd to 8th gestational week. And it is diagnosed with a sort of clinical triad. So these patients have a short neck. They also have deemed to have a low lying hairline, and they have significant limitation of range of motion in the neck. This is a congenital / developmental anomaly, and there are both sporadic mutations that occur, or it can be inherited, with some families have found to have mutation in the GDF, either 3 or 6, and there's also another alphabet sort of genetic anomaly of the MEOX1. So in terms of the GDF, that is thought to be involved in proper bone formation. It is a autosomal dominant inheritance, while the other entity, the MEOX1, creates a protein that the MOX1 regulates, and that is involved in the separation of virtual body formation. And the GDF basically stands for growth factor, growth differentiation factor. There is a slight female predominance in terms of the Klippel-Feil Syndrome, with a ratio 1.1 to 1, and there is found to have a higher incidence in Native Americans. There is an association with other syndromes. In particular, it's found to have an association with the fetal alcohol syndrome, golden haar, and another entity, Wilden Knack. I'm sorry if I'm hopefully I'm saying it correctly, but that has anomalies in terms of the eyes, the ears, and the cervical neck vertebral body development. There are other systems that Klippel-Feil syndrome has anomalies with. It's supposed to have there's issues in terms of the renal or kidney anomalies. So you can get either ectopia of the kidney, agenesis, dysgenesis, malrotation, duplication. There's also an association with congenital heart anomalies, with VSD being the most common anomaly that they might have. They also have found to have like a higher incidence of atrial septal defects, coarctation. They also have other cranial and facial anomalies with asymmetry of the cranial facial osseous midface regions, and then there's a higher instance of cleft palate. No one really knows what the pathogenesis of Klippel-Feil is. There are two competing theories. So the more I think the more popular or the more prescribed pathogenesis is thought to be that there is a vascular disruption that leads to failure of segmentation, and then that leads to this formation of a single mass of bone. So that the initial insult or root cause is some sort of vascular disruption. Now, the other hypothesis is that there is a primary defect of the neural tube. Right. Let me just, sorry, I'm getting paged. Can I just put you on brief hold? Let me get the another laptop, and I'll be back in 1 second.
Yeah, sure, no problem.
Because there's a stat case, sorry.
Yeah, sure. We'll be back in 1 second. Some technical difficulties.
Right. Okay. Sorry about that. Hopefully we'll get that sorted and soon.
All good.
Okay. So let's move. Right. Now, typically these patients with the Klippel-Feil syndrome, they have what do we have? We have, they present quite commonly with like progressive scoliosis, or scoliosis is a common presentation. They are, as you can quite clearly see here, they're predisposed to congenital spinal stenosis. So since it especially has a predilection for the cervical spine. So Klippel-Feil has a sort of, higher association with the cervical spine anomalies. And then 50% may have the allantoaxial instability. One thing to know, which I found out, doing this, is that, if they are going to have any form of procedures, i.e. Intubation, laryngoscopy, head manipulation, they have a higher risk of allantoaxial subluxation and craniovertebral dislocation. So they really need, they should have an MR before any of these procedures, just to delineate any of these issues. And so they have a lot of like these congenital fusions. So here, both on X-ray and MRI, you can see these sort of, here's the C2. It has this like wasted appearance here. This is the subdental synchondrosis that so in normal, it's very easy to remember, but this whole block is the C2. And then here's C3. And we don't know if there might be any sort of, probably a fusion going on between C2 and C3. And then these vertebral bodies obviously look abnormal in terms of their segmentation. And they are prone to getting degenerative. This leads to degenerative changes, especially of the intervening disc bases. And then here, this is the reason why they are prone and predisposed to the congenital spinal stenosis. Okay, so it is deemed that if they have fusion anomalies above C3, they have to avoid contact sport. So they really should not be playing any sort of aggressive sports. And below C3, if the child wants to play contact sport, they have to have close monitoring, because you can quite clearly see it can lead to issues. And then here on the X-ray, you can see that sort of fusion here posteriorly. And then here, same patient. So they can have, abnormalities both in cervical spine. They can also have, there are different types, and depending on whether there's involvement of the thoracic or lumbar spine as well, they can be classified into various like Klippel-Feil type 1, 2, and 3. So if there's cervical fusion in combination with lower thoracic or lumbar fusion, it's classified as type 3. And here's beautifully like this 3D volume rendered CT sagittal, the T-spine. You can see the posterior spinous processes are severely fused. And this is what I'm talking about. Again, you can see that segmentation anomaly involving the thoracic spine, and you have this like typical wasted appearance of the vertebral body. And so this is actually has a sign, and it's called the WASP waist sign. And here you can see, the fusion going on. So the more you look actually on MR, even though we say MR is not great for osseous detail, you can start noticing these osseous anomalies. Right. So keeping, and I think this is also a nice segue into our next entity. This is a case of a child with Klippel-Feil syndrome who ended up developing basilar invagination. And so this is what we're going to discuss. So basilar invagination is occipital cervical dysplasia with upward displacement of the foramen magnum and upper cervical vertebral body, causes compression of the brainstem and cord, and it needs to be surgically treated for surgical decompression of that upper cervical cord. and posterior fossa with or without sort of fusion to treat any instability. So there are several forms. Primary form is associated with hyperplasia of C1. We talked about the various odontoid anomalies that also now come into play. Klippel-Feil syndrome. Again, we come across T21/Downs, which is a very common entity. And then later in the talk, we also will discuss about achondroplasia. There is also some association with a less well-known, and not less well-known, but less common entity, the clinocranial dysplasia. And there are some points where Chiari-1 can also have basilar invagination. So, and basilar invagination is can be thought as both primary, where these are the sort of primary forms associated with it, and you can also have secondary basilar invagination. So in that case, if it's a secondary cause due to an acquired systemic disease that causes softening of the bones of the skull base, such as Paget's, osteomalacia, rickets, osteogenesis imperfecta, rheumatoid arthritis, and a common entity, ankylosing spondylitis, that is termed more such as basilar impression versus basilar invagination. But effectively, they kind of result in the same problems of that sort of cord compression and brainstem compression. So when we think about that, excuse me, what are some of the ways we can, obviously I'm showing you very gross examples, but if there are any other less gross example, more subtle cases, you want to think about a couple of lines. So we'll first of all discuss Chamberlain line, which is a line joining the back of the hard palate with the opisthion. And literally, you want to see that on the sort of lateral view. You want to get that straight sagittal of the craniocervical junction. Now, it was originally described, but it's very hard to view the opisthion on X-ray, especially when it's abnormal. Here's a typical example. I mean, where is that? Where is that back of the skull, right? So, in order for the Chamberlain line to be normal, has to be it has to be either sort of the less than 3 millimeter or half a dens above this line, and then if it's abnormal, the dens is either greater than 4.5 to 6 millimeter above that Chamberlain line. And here I'll give you some example. Obviously, this is a gross anomaly here, and you can quite clearly measure these lines on CT much more clearly than X-ray. And here you have to find the hard palate, so the back of the hard palate to the tip of the opisthion. And obviously this is, you don't need a measuring tool really, but this is pathologic. But you can also see that there's more skull base anomalies going on here. It probably the Odontoideum. You have to be a bit careful on this point also, because both Chamberlain and McGregor, the hard palate can be distorted if there are any sort of abnormal facial anomalies, facial configuration, or any sort of issues with the palate, i.e. in a high arch palate, with some of these syndromic entities that they might have. So next we go, again, similar to the Chamberlain's line, we have McGregor's. So again, you look for that posterior margin of the hard palate, and then it's really not the sort of tip, it's really the inferior edge of the opisthion. So just there, and it's just a modification of the Chamberlain's line. And this is the sort of same case with that Klippel-Feil with the basilar invagination. And then, as I said, any sort of lateral tilt and coronal plane, you can you can assess for lateral tilting, if sort of, especially if it's congenital, and braces can also affect and alter the accuracy of this line. So McGregor is typically, if it's abnormal, the number you want to think about is 4.5 millimeter. So anything above the dens is above that, it has the impression. And then finally, we just quickly run through for completeness, McRae's line. Again, it's a line that sort of that you can measure on the lateral skull X-ray, CT, MR, and it's a line joining the basion with the opposition. So I kind of think of it as sort of, that's the line I use really when I'm assessing for any sort of cerebellar tonsil ectopia or a Chiari malformation. So the normal has to be sort of no dens is above this line, and obviously if it is, it's abnormal, and that's sort of basilar invagination. And here we'll just illustrate that with a case with Down syndrome with basilar invagination. So here is that sort of normal appearance, and you can see the dens here is abnormal, so it's a little bit sort of hypoplastic, but it's kind of like a little bit blunted too. And it's just this, so this is McRae's line. Here's the Chamberlain's line, and here's McGregor's line. So you want to find that sort of posterior edge of the hard palate, and you can quite clearly see that there is basilar invagination going on. But I also want you to recognize here, what else is it doing? Oh dear, it's like that craniocervical junction is markedly narrowed, right? So that's a no-no. Right. So, and I want to finish and complete the talk on our last entity, achondroplasia. So it is the most common form of short-limbed dwarfism. So it basically affects the proximal limbs, both the humerus and also the femurs, has a predominance. It's either autosomal dominant or sporadic mutation, and it is a mutation in the FGFR, which basically is involved in cartilage formation. The bones that are affected primarily are sort of for endochondral ossification. Why does that matter? And it's all the bones that form the endochondral ossification. So we have to remember achondroplasia is a systemic, it affects the entire skeletal system. And we will focus on the specific neurological complication, but basically the skull base is formed by endochondral ossification, whereas the rest of the cranial vault is formed and has membranous ossification. So then you have these two differences, and because of this difference, that leads to the typical appearance of a very small skull base, where the skull base is not growing, but the rest of the skull is growing. So then the rest of the skull plus the brain and the cord is growing normally, while the skull base remain small. So then that leads to what we see is the I have to go back and forth, but you have this sort of enlarged cranial vault relative to a small skull base, and then you also have that also leads to the frontal bossing appearance. Okay, and then obviously you have stenosis at the craniocervical junction, and then sort of problems with sort of kinking of the cervical medullary junction. They also have a propensity for communicating hydrocephalus, because there is also obstruction of the venous outflow, specifically at the sort of sigmoid sinus. And then in terms of the not just the C-spine, but the rest of the spine, you have congenitally narrowed spine due to short pedicles. So here's the sort of classic X-ray appearances, you can have the posterior scalloping of the vertebral bodies, most pronounced in the lumbar spine. For some reason, there has a more of a predilection into the lumbar spine region, and then you have the interpeduncular distance, progressive decrease in the interpeduncular distance, also in the lumbar spine. Then they also have additional anomalies with flattening of the roof of their hip joint, so the acetabular fossa. You have metaphyseal flaring, short-limbed appearance, and you have that squared iliac wings. And then if we move on to subsequent MR imaging, with that congenitally short, narrowed pedicle, that leads to diffuse congenital narrowing of the spinal canal. And then here, there's sort of anomalies at the craniocervical junction also. So, and this was a case, teenager, female, presents with sort of shortness of breath, lower extremity numbness and tingling. And then here, even though there's still space, there's something else going on. You have sort of a very narrow caliber of the cervical cord with abnormal increased intermedullary signal. They had a diffusion sequence with that to make sure, but this is basically what this is a classic sign that we will talk about. So you can see the abnormal intermedullary T2 signal. So we have a small foramen magnum, the short pedicles, then we have the posterior scouring and that congenital narrowing, and that congenital narrowing is really marked here in the lumbar spine region. And then we have this abnormality in the cervical spine. So this is a very unique radiological sign, and it's related to a high cervical myelopathy that is seen in children or patients with achondroplasia. It affects really the high cervical cord, affects the anterior horns of the gray matter, and here's a sort of schematic back to our med school days of anatomy. And so it is either known by several names: owl eye, fried egg sign, aka snake eyes. So basically, they're two sort of bilateral hyperintense symmetric ovoid foci best seen on axial T2. And if you want to make sure that it's not an acute thing, it's not an anterior, because this looks very similar to an anterior sort of cord infarct. If you're worried, always get the DWI. But basically, it's myelomalacia going on. Right. So that will wrap up, and I want to just help you remember some numbers. So these are my tips. So try and remember these numbers in terms of spine development. So for C1, remember 3 and a 7. So those are when the sort of the fusion of the posterior neural arches, and then the body and the arch fuse at age 7 years. And then for C2, you want to think about 2 and 3 for the neural arches fusion, and then C3 and C7, again 2 and 3 with the posterior neural arches, and then with the fusion of the body from 3 to 6. And then hopefully I helped you recognize the os odontoideum, as it has surgical important implications. So that's all I have, and I'm going to open it up to any questions people may have.
Thank you so much, Jessie. That was incredible. It was a very difficult section of anatomy. It can be very tough to understand what's going on a lot of times. A lot of anatomic variation and pathology. Yeah, so that was great. Anybody from the audience have any questions?
Maybe I'll ask. Oh, someone said in their chat box.
Okay, which measurement is the best to use?
For what?
Do you have a specific pathology that the question is? William Albano had asked that question. Just for specific entity. For I guess for basal invagination.
I think you can use any of the oh, which one do I use? I mean, the cases I see are so gross that it really doesn't require measuring. But if there's any I would, the way I would do it is, you know, if there's any sort of subtleness or subtlety, then you could try like either the Chamberlain or the McGregor's. They're kind of very similar, and then you can always do like McRae. But I would also recommend that you look at the coronal of the C1 C2 alignment to make sure that there's no asymmetry or tilting, because then that would basically make the measurements kind of not invalid but a little bit incorrect, because of that head tilt, you know, it can be off. So you want to use it with a view that measurements are great, but you also want to trust your own gestalt, you know. Hope that makes sense.
Yeah, I think so. I had a question. Do you guys ever do flexion extension imaging, or how much do you do
Yes.
it, or do you?
Yeah, we do actually.
Mhm.
Yeah, we do. We basically okay, so that is a case by case basis, and it's
Mhm.
really ordered by our neurosurgical colleagues. So we will do it for whatever reason that they want. So we don't do it that often, but we do. And we do flexion. We do both flexion extension on CT and MR. If there's and on either case, it has to be, the neurosurgical team has to come and be there, you know, in the scanner room while either they do it, or depending on how unstable or not stable or stable the thought is of the C-spine. So that's how we do it. I had one scary experience where there was, and you know, it doesn't necessarily have to be trauma. There was this one case that I remember quite clearly. There was a teenager who basically had an infectious disease actually in their chest, but then that I think it was either histoplasmosis or coccidiosis. But anyway, it basically they ended up eroding into their like T-spine and lower C-spine. So the infection spread into the vertebral bodies, and you know, even though the child was like walking on the floor, or the teenager was walking around on the floor with a collar on, like by imaging, the infection started basically like eating the bone away, and so they were being scanned on MR, and luckily the tech recognized it and then got them out. But you know, we had to call neurosurgical team like to come down stat. So with those cases, I mean, neurosurgery was involved in that case, but it wasn't obvious how bad it was until they got in the scanner. So but I should always you should always have your neurosurgical team on standby, I would say. Any other questions?
Yeah, makes sense.
Is there another one? There's another one, I think, right?
Any other questions from the audience?
I thought, isn't there another one?
Is there another one? I can't see. Let's see.
Oh yeah, no, there isn't.
There's just one. Yeah, so there's no more questions. I don't want to take up. I know you're on a busy service day, so thank you so much for doing this. What a wonderful lecture. And then for anybody for next month, we'll be having Asha Sarma from Vanderbilt, who will be talking about abusive head trauma, and that'll be May 11th. So hope everybody can join us there. And thank you very much. Thank you, Jessie, for this wonderful talk. And yeah, have a great month, everybody.
Thanks, Adam. Thanks for the invite. Okay.
Thanks.
Have a good day,
Take
everyone.
care.
Take care.